Good afternoon, everyone. Welcome to today's ECHO. I'm Dr. Chitalu Chanda. I'm an infectious disease physician. Thank you.
Right. Thank you so much, Dr. Chanda. Just as a reminder to everyone that we keep our microphones muted until we have been requested to unmute, or at the point we'll have the discussion when we need to ask questions and through the presenter as well as the other subject matter experts. Dr. Chanda, I'm throwing it back to you to take us through the didactic. Thanks.
Thank you so much. And we can get started. Seeing we've got quite a good number, so I think we can move in that direction. So have no conflicts of interest to declare and disclose. Are you able to see my slides?
Yes, we can.
Okay, and they're moving.
No, we're still on the landing page. We're on the first slide with the heading.
All right. I think now it started to.
All right.
We are looking at non-tuberculous mycobacterium in people living with HIV. And we will focus on three main objectives for today, really just to look at what's the burden. It's always important to describe how common something is. And then we will look at the principles of assessment of somebody who is suspected of an NTM, especially if they're HIV positive. And then we'll finally close out with the principles of management. We'll look at a few things like initiation, monitoring, and looking at ATT and HIV care in patients with non-tuberculous mycobacterium infection. So we have our first poll.
All right. The first question reads: Mycobacterium avium complex is found only in the hospital. Mycobacterium avium complex is only found in the hospital. Option 1 is yes. The A says yes, B says no. I'll read the question when I launch the poll. Poll number 1 says Mycobacterium avium complex is found only in the hospital. A, yes, B, no. I have launched the poll, so you may go ahead and select your responses by selecting the appropriate answer. And just to mention that we are unable to associate your response to your identity, so you can be free to select the answer that you think is the most appropriate, and will not attach it to you. All right, so the voting is very good so far, with more than 50, about 50%, close to 50% having voted. Just encourage everyone to participate. It helps the didactic presenter on what to focus on. All right, I'll just leave it on for a few more seconds. All right, so I'll end the poll here. We have 21 people that have participated, and 86% of the respondents thought B is the correct answer, which is no. So the majority thought B is the correct answer, that no, it is not only found in the hospital. Dr. Chanda, back to you.
Yeah, thank you so much. And I will discuss this poll question as we go on. But it's interesting to note that quite a good number of us, I think, are aware of where this organism can be found. So with that, we would like to go through microbiology of non-tuberculous mycobacterium. And starting with that, some literature will say non-tuberculous mycobacterium other than Mycobacterium tuberculosis mycobacterium. So basically, this is other TBs other than the Mycobacterium tuberculosis complex. Okay, so when you think about NTMs, we are thinking about Mycobacterium, but this is Mycobacterium that is not the typical Mycobacterium that causes TB. So in this class, there are over 190 species that have been so far reported. So it'd be good that one of you can further on find maybe a new type of Mycobacterium that is other than Mycobacterium tuberculosis complex. So when you think about it, we have Mycobacterium avium complex. I put this first because it's really the commonest you're going to find that causes syndromes or disease entities in humans, especially in humans who have advanced HIV disease or those who have HIV. So I put that on top so that it can help you to remember. Then other Mycobacterium that really is not part of the Mycobacterium tuberculosis complex includes leprosy. Okay, so leprosy is caused by Mycobacterium leprae, which is also similar in structure to what you have with Mycobacterium. Then others that you will find are Marinatum, you find Kansasii, Potutum, Zengai, you get Xenopi, Ulcerans. The list is quite endless. But I've focused on these are the common ones that you are going to find causing disease entities. And when you look at or you explore your patient's history, some of these will be related to what the patient does and where they're located. Okay. So I thought that we could look at the structure of this Mycobacterium. So when you do a microscopy, what you're going to see is basically similar to what we see with the ordinary Mycobacterium tuberculosis complex. So you smear with a microscopy, we will basically show an acid-fast bacteria. And you can see how they stand there on the right, which is B. I must mention that this picture is from, was taken by the author, as you can see down there. So you can see that this organism basically will stain when you do your AFB smear, will stain similarly with what you get with TB. So using a smear, it's very difficult for you to differentiate if you're dealing with a non-tuberculous Mycobacterium or TB. And this is because both contain lipoarabnomannan and both contain alabdoglycan, okay? And all these have mycolic acids, embedded in the cell wall. So your routine gram stain will not really give you much information, but when you do spatial staining with Oramine or Zn stain, you're able to get this picture where you have a dark background and the organism will stain as a gram-positive bacilli, okay, that you can see on your right there. And these principles also help us with target for therapies. So you find that some of the drugs that we use actually for treatment of TB will be used for treatment of non-tuberculous Mycobacterium. Probably there might just be differences in terms of the combinations. And then we also find that besides that, they also have the DNA and they also have certain genes that are encoded in the DNA. So you find that some of the NTMs will actually possess the RPO bean, which usually is detected by most of the experts, but the levels that you find are quite very low, okay? So what are the dynamics when you think about non-tuberculous Mycobacterium infections? Probably the first thing I wanted to look at is the host. For somebody who has certain characteristics, the risk factors will be dependent on the immunology or immunity of that particular person. So if they have advanced HIV disease, then you are going to get that patient having an increased risk of having these infections. Okay. So this risk is higher in patients who have very low CD4s, especially CD4s less than 50. And this is very key when you're going to think about the principles of management, because then you want to push your CD4s above that level. I must mention that for certain non-tuberculous Mycobacterium like MAC, you also might want to have the viral load less than 1,000. So besides the CD4s just being less than 50, the viral loads above 1,000 increases the risk of somebody actually having these particular infections. But other than that, there is also consideration for structural lung disease. So if somebody probably had TB before, the lung is damaged, there's fibrosis in the lungs, then that becomes a good media actually for development of these non-tuberculous mycobacterium co-infections that come out later. Some of these also depend on trauma. So if you injured yourself, there's a likelihood that you can actually auto-inoculate in that particular environment, okay, where there is a wound. The next one is actually the environment. Most of this, when you talk about the environment, we're thinking about the physical environment. So what we looked at is that non-tuberculous mycobacterium basically are ubiquitous in nature, meaning that they'll be found in the environment, they'll be found in soil, they'll be found in water. So aquatic environments become a good area for finding these. And remember, the transmission probably is mostly going to be like inhalation or ingestion, okay? So sometimes as water is passing, you have these droplets, and sometimes contact. So you can find also this occurring in hospitals, and you can also find it in soils. Then the agent, so you look at its characteristics basically, is that it really is found everywhere in the environment, wherever you are. So this is very key. When you collect that urine lump, if you don't process your sample of urine based on the standard operating procedure and laboratory guidelines, you risk getting now a false positive result, because you find in the hospital setting, hospital environment, whichever environment, you're going to find these organisms freely living in that particular environment. So please, let's follow, because now these can affect your interpretation of your results. Then the next thing I wanted to look at is just the time frame. So most of these organisms really, when you present with a syndrome, it's mostly as a result of recent infection, okay? So somebody got exposed to it more recently, and that's how they develop the disease. It does vary in terms of the time between the exposure to development of symptoms based on your immunity and the site of inoculation. So sometimes it will take a few weeks for you to develop symptoms, sometimes it will take a bit of time. And this is where you find some patients might present with GI symptoms much, much later, maybe beyond 3 months to 6 months from the time of exposure. Okay. So having looked at the dynamics, I wanted us also to look at how common is this in our setting, okay? So this is interesting because this is data that is more recent from our region. So in 2015, I think a cross-sectional survey was done in Zambia by Dr. Kapata and team, which included Professor Mwaba and Dr. Sunkutu. You notice that this survey, because it was cross-sectional, has some limitations on how we are going to interpret, but I think it gives us very key information. Firstly, they looked at how common is this amongst patients who are suspected to have TB. And probably that's where you're going to get these cases. You're going to get this occurring in patients who suspect to have symptoms of TB. So they will have the cough, the fever, night sweats, and weight. And that was the entry into the study. So basically, some of the symptoms, when you come to talk about it, you find that there's that similarity. So we had about 6,000 people that suspected to have TB. And of these, 15%, which was 923, had an NTM. And this was confirmed by culture. So it's quite a good number, okay? And then we also look at how many had MTB. It was 4.3%. And those who had co-infections with NTM and MTB, it was 0.02%. The only risk is that the number of people that were HIV in this population was really very low. Okay, so very few people had been included in this study and were HIV positive. So basically in Zambia, one thing we can say is that NTMs are around and they have been isolated. And it's very possible to get TB and NTM co-infection in one particular patient, okay? Then in Botswana, I think a similar study, which looked at now people who are living with HIV, and you can see that these patients had a clinical diagnosis of TB. It's been something we've been talking about based on an X-ray. And they did isolate non-tuberculous mycobacterium in about 20% of patients. what a clinical diagnosis of TB. And these are patients who probably had a negative expert and just had an X-ray that was bad and based on symptoms. And then further workup actually isolated non-tuberculous mycobacterium, the NTMs. Okay, so our number is good. Then probably what I wanted to mention also, that's something that comes out from this study, is that really most of them might have were HIV positive, Botswana, but also they compared the outcomes of patients if they had an NTM compared to those who are TB. And the thing that comes out is that some of the patients would then get empiric TB therapy and then continue with that TB therapy until they finished. And treatment success was actually noted in around 70% of these patients. But what comes out is that those who had NTM infections didn't do very well. And this is very key. So all these patients that we're suspecting and thinking about having clinical diagnosis of TB, probably we could be thinking about them having either NTMs or both co-infections of MTB and NTMs. There's a big difference because now when you look at Kenya, which is also within our region, this study, I think I've put them in the references, they found the prevalence of NTM infections amongst people living with HIV to be about 9%. So it's possible that probably numbers have gone up or down. I'm yet to come out with more recent evidence and data. So before we look at the diagnosis, I thought that then we could look at how do you arrive and what tests would you do if you want to approach and evaluate somebody for a non-tuberculous mycobacterium infection. So it's very important that you combine a lot of your tests that you have. And the first one would be to get a smear. Now, a smear is likely to be negative in a good proportion of patients who have an NTM infection. So if you do a smear and it comes out negative, that doesn't mean that there's no NTM. It could still be there. If you get a positive result for a smear, then you are well and good, okay? And probably you understand now why we ask you to repeat the culture, because now some of the patients who have TB infection, especially the MDR, we find that some of them get really infected with an NTM later on, and probably they have a risk factor. So a smear is something that you could do and you might do, and it helps to do your testing. You could also do serology for MAC. It's not very sensitive, but because it's about less than 60%, just doing serology for MAC. And then you could also do your nucleic acid testing. These are the NAT, the experts, more likely to be negative in your patients. And then you also have cultures. So the cultures you can do from different tissues. You can do your cultures on your biopsy. And then you can also get your culture from your sputums. The normal culture that we do for the sputums, the AFP, you will find that they are able to identify, especially on the solid medias, based on the growth of the cultures. And they can also do drug sensitive testing for you based on the culture. I want to highlight a thing on imaging that it can support your diagnosis. So you need to have an image done by your patients. So basically you need to have all these tests done for your patients, and that will improve the yield of diagnosis. Probably wondering, what about a biopsy? Why would you want to do a biopsy? Remember, the presentations might vary in the way your patients will present. Some of them will present with abscesses in the neck, and some of them will present with either abscesses in the abdomen, and you might have to collect that specimen and take it for biopsy. Okay, so next slide. Now, which one of the following is a feature of chest radiography in patients with NTMs? Oh, that's for you, Dr. Singini.
Right, thank you so much, Dr. Chanda. This is the second poll question, which reads, which of the following is a feature of chest radiograph in patients with NTM infection? A is abnormal, B is normal, C is all of the above. All right, so I'll repeat the question as I launch the new poll. Which of the following features of a chest radiograph, which of the following is a feature of chest radiographs in patients with NTM infection? A, abnormal, B, normal, and C, all of the above. So we have three options to choose from. You can choose the best answer and we will discuss the results right after. So again, I encourage everyone to participate in this poll. It helps us understand where we need to focus our conversation on NTMs. And just also as a reminder that we are unable to link the response to the person who polled. So these remain anonymous, not even the host can tell. All right, so the response is pretty good. We are at over 50% now. I'll just give it a few more seconds to give chance to those that may have struggled with connectivity to give us their thought. Again, the question is, which of the following is a feature of chest radiograph in patients with NTM infections? So if you have just joined us, we are looking at non-tuberculous mycobacteria, and this is a presentation being done by Dr. Chitalu Chanda, an infectious diseases expert. All right, so I'll end the poll and share the results. We have 71% of the respondents who thought all of the above, which is option C, was the correct answer, and 16% thought it's normal. 14% thought abnormal was the correct answer. Thank you so much for following. I'll circle back to Dr. Chanda to take us through the next part of the session.
Thank you so much, Dr. Singini. So interesting finding and response from the team, and probably we'll discuss this in the next few slides. So my slides are not moving. Okay, now they can move. So probably, yeah, the key thing is when you think about your imaging as part of your diagnostics for your patients, remember we mentioned that you might have to require imaging done for the patient for you to say this is this. So you find that you probably, because they'll present with pulmonary symptoms, you're more likely to get an X-ray done. So you find that amongst most of the patients that have been noted to have pulmonary changes, especially in the HIV positive population, there's a myriad in terms of the way they present. So less than 10% of the people present with a normal X-ray, so that you can find a normal X-ray in terms of the way the patient will present. And these are patients who are likely to have dissemination. So if you do a blood culture with your back test, you're going to get a positive result for MAC, okay? And remember, MAC is what we say to be the commonest. So you find that some of your patients who probably have symptoms of TB, but you do an X-ray that might look normal. And then we also have miliary in terms of presentation. So it really is not just Mycobacterium tuberculosis alone that presents with a miliary picture. You can get that also occurring in patients who have non-tuberculous mycobacterium. Then you have fibrosis, cavitation, nodules. I must mention the top three are also likely to coexist in patients who have bronchiectasis. So you can find sometimes some patients who have cystic features that you can find on an X-ray. Sometimes you can find destruction that you can occur, there's lung fibrosis. So there's a myriad in terms of the symptoms that your patient can present with. If you did imaging in other tissues, you can then appreciate and see sometimes abscesses that can be in the spleen, and sometimes it's just enlargement of the spleen. You can find masses elsewhere, sometimes you find there's enlargement of the liver. And then you can also do imaging for bones, and you find there's osteosclerosis, okay? So that you can find that if it's going to the bone, then there are changes that can occur in the bone tissue. So really the symptoms and the imaging and what you're going to get will depend on what you're going to request for. And sometimes most likely might be in the chest. I should mention here that in the chest, some patients actually can present with features suggestive of an effusion on an X-ray. So when you think about it, really what TB can present like is what an NTM can present like. And some NTMs really like to present with pulmonary features, less non-pulmonary, but it's possible that the same organism can be in other tissues, okay? So now we'll go through the assessment of a patient with non-tuberculous mycobacterium. The first thing I want you to remember is know the syndromes and symptoms, okay? So I put down a list and summary of the common symptoms that your patient might present with. So we start with the lung. Most of the patients who present probably with cavitation and fibrosis on an X-ray, but the classical symptoms that they will present with will be cough associated with fever and weight loss. And some patients might have that cough presenting as hemoptysis. So that's something to remember and think about. So the symptoms can actually be just pulmonary symptoms. And then we move on to musculoskeletal, and probably before we get to that skin, okay? So integumentary, you find that the skin can have ulcers, nodules, okay? So when you think about ulcers, please, now in the era of internet and all that, I couldn't get permission. I wanted to show you a picture for a patient who has an ulcer, a chronic ulcer that's related to Mycobacterium ulcerans, and it's called the Blurry ulcer. Okay, it's called the Blurry ulcer. So you can Google that and you find how it looks. So it's quite a big ulcer that you can find on the legs. And most of us walk around and seen these patients walking around nicely. And it could just be because of a non-tuberculous mycobacterium infection that might be in that skin. And then we move on to the gastrointestinal system. So in the gastrointestinal system, some of these patients who present with a chronic diarrhea. So remember now we're thinking about people living with HIV, right? Who have advanced HIV more likely. These are patients who now can present with chronic diarrhea. So as you evaluate these patients for that chronic diarrhea, you might have to see, is this MAC or is there another co-infection? So chronic diarrhea might be a presentation that you might find. There have been a few patients who actually have presented with intestinal strictures. So you find these patients are constipated, they can open bowels very well, they have abnormal bowel movements. So gastrointestinal might be something that you might have to think about. What about the bones? So in advanced HIV positive patients, you have bone marrow suppression, probably. So these are patients who present with anemias, okay? So you just find all the white cell line, the cell line is gone, the white cell, the red cell, all the cell lines are actually depleted. So you remember the different tissues, the different symptoms that you're thinking about. You need to then get tissue and evaluate. So you need to think about, is it in the lungs, is it in the GIT, where is it, okay? And then you can also get it in the lymphatics. So here you're thinking about lymph nodes, okay? So these lymph nodes can present as primary, okay? So they can present primarily as lymph nodes in the cervical region, but they can also present as an iris, okay? So you find that patient just has worsening, and then you have these lymph nodes and iris. Now, this is very key. Most of us clinicians, what we do is we get that tissue, we send it to the lab. We don't request for a gram stain. We don't request for an AFB smear. We don't request for an AFB culture. We don't request for a gene expert. So that lymph node could be just the normal Mycobacterium tuberculosis, but that lymph node can also be MAC. And you find you treat a bit and the patient improves slightly, and then the lymph nodes come back again. So you need to think about this adenitis. Is it just purely TB itself, or is it non-tuberculous mycobacterium? That might have been the organism that we might have isolated. So I know we're talking about NTMs in HIV. I thought that this is probably time for us to also look at non-tuberculous mycobacterium. Just recap on what you can get if somebody has leprosy, okay? So they can have a non-tuberculous mycobacterium, which is leprae. So again, they'll present with skin hypopigmented, there's loss of skin sensation. You find if you palpate the nerves, they're quite enlarged, especially the popliteal, okay? So then sometimes they'll just present with ulcers in the digits. Then in the heart, for those who have leprosy, they can get some ischemia, sometimes it's myocarditis, and sometimes pericarditis. That can also occur with most of these other NTMs. Then if really there's extensive nerve damage, there's claw hand and foot drop that can also arise. So when you think about the NTMs in terms of really the presentation the patients will have, you have to really think, you move from head to toe, because these, just like a normal Mycobacterium tuberculosis, can affect any tissue. that you have to think about, okay? So the liver is never spared. You can get granulomas within the liver, okay? So you get this gaseous necrosis within the liver tissue. And this is a patient, before you even start the ATT, you find that the liver enzymes are slightly raised. So again, just think about the symptoms, okay? What is the symptom? Which organs are there? Probably it might be there. Can we get tissue and biopsy it? So when you finish with your history of this patient, in terms of what they are presented with, you are assessing this patient. The next thing you need to look about is the HIV. When you think about the HIV, you are going to really focus on the CD4 and viral load, because we've said that CD4 is less than 50, are a risk factor. And then viral loads above 1,000 are also a risk factor. But these also help you with your therapy, okay? Because when you are going to treat these patients, you then want to continue the therapy until the CD4 is above 50 if there's improvement of that CD4, but sometimes your patient CD4 will not improve. And then the viral load, you want it to get less than 1,000, okay? So again, as you're treating your patient, you want to attain that, okay? Now, remember from our starting slide, we said about 0.2% of patients actually can have co-infections of NTMs and Mycobacterium tuberculosis. So you really want to also screen for other opportunistic infections. So again, because it's advanced HIV disease, you make sure your crypto wake-up is done, okay? If the crypto serum antigen is negative, again, you want to see, does this patient have any other symptoms that might suggest either a viral infection like CMV? You want to wake up for TB. So you really have to be comprehensive in how you're going to screen for other opportunistic infections, okay? But it was just quite a reminder for us to think about. So now when you've done your assessment, you can then go to focused assessment depending on the symptoms and the syndrome has. So I picked two common syndromes that you're going to think about, pulmonary syndromes. You want then to get a culture. So this culture should be at least 2 specimens, okay? Why do we do this? Because if you have a patient who's got a damaged lung, you're going to get that lung being colonized by an NTM like MAC and not really present with any symptoms. So you want to collect 2 specimens, and ideally, if the culture can show that this is actually the same organism, then you will not treat it as a colonization. And when you think about even the diagnostic workup, you really have to have now a patient who has symptoms, and these symptoms must be accompanied by an imaging that is showing changes, and this imaging should then be supported by Mycobacterium isolation. So if you get a bronchoalveolar lavage, just 1 specimen will be adequate for you to make an empiric diagnosis of an NTM within the lung. So there is a diagnostic criteria that you can then adopt based on this. Again, when you're waking up the lungs, please don't forget to wake up for fungal infection and other malignancies. So malignancies, the reason I'm saying is because it becomes a risk factor for this patient to present actually with an NTM. So you wake up, should then be a sputum culture that is done. You do your workup. If it's advanced HIV disease, then you completely wake up with your urine lamp. Remember, urine lamp will not differentiate if you're dealing with just NTM or MAC. So you need to get an AFB culture done on your patient. And then if you isolate that particular organism, then you would say, this is probably an NTM, and then you marry that with your imaging and the symptoms that your patient has. Some of these symptoms, actually, I just wanted to mention, when you start therapy, they might take a bit of time for them to actually resolve, okay? So that's for pulmonary. The next thing I just wanted to mention now is, how are you going to then explore someone who's got extra tissue? So if it's in the GIT, I wanted to start with this because it's the second commonest site you're going to get. Again, you want to get a colonoscopy and a biopsy. Okay, so again, it doesn't really matter if it's in the bone. You're thinking this NTM is disseminated in the bone, this NTM is disseminated in the blood. I think you can then collect that tissue and send it for an AFB culture. Okay, so your bone marrow, you can get a colonoscopy and biopsy if someone has chronic diarrhea. And sometimes you might be able to stand and show, oh, there's fibrosis, there's stricturing. And sometimes you find that within the lumen, you find that within the your biopsy, you can actually see the Mycobacterium there. So you can still get a biopsy of the bone, you can still get a biopsy from the colonoscopy, and then you can still do a blood culture with the bactet, and that might show you that this is probably TB, okay? So the next thing I wanted you to look at and for us to focus on is then what are the principles of management, because this is very key. Again, management should then be comprehensive. Like we've said, you want to wake up for advanced HIV disease. You want to do your CD4, your viral loads. You want to wake up for crypto. So your management of this patient based on assessment then should be comprehensive, okay? So your patients might require a physiotherapy, okay? So because it's comprehensive, you might require a multidisciplinary team. You might require surgeons. If it's an ulcer on the wound, if there's stricturing within the gut, you might require a surgeon, you might require a pulmonologist, a physiotherapist. So again, your workup really will be comprehensive. Then your next step would be very to improve the symptoms of your patients. Sometimes you might have to give drugs that improve the airway. Okay, some patients who, if they have bronchiectasis, they have stricturing of the airway, constriction of the airway. You find that they have respiratory symptoms, and that can improve either with using other therapies. And then the next thing you want to is to reduce recurrence. Now, when we talk about reducing recurrence here, what we are interested in is reducing the recurrence of that particular condition, but also we want to reduce development of resistance. So we don't really encourage monotherapy if you're going to do care, because the risk of developing resistance for the common drugs used is at least 50% if you're using a monotherapy. So you find the patient will not improve clinically. Because your patient will take multiple drugs, you want to look at drug interactions, okay? So these drug interactions can arise from interaction between ART, can arise from interaction between ATT and ART. And then you want to monitor your response of these patients. Most of the patients respond by having a culture that's negative from either the tissue or from blood if it's disseminated by 6 months. And if by 6 months there is really no improvement, then you might have to consult as a team. And most of the time you find that if you continue the treatment, there's actually improvement. You find that most of the patients' treatment is quite long, okay, but most of them tend to clear by a year. So at least by that time, you would have gotten a viral load and CD4 improving. Okay, so few things about the principles of therapy that we can then further dive in. So the first thing you also need to remember is drug interactions. Now, if you've got a patient with a MAC infection, if you've got a patient with a fortuitum, whichever NTM you're going to think about, you can start your ART as soon as is possible. There's a small risk of virus developing. You can start that therapy within 7 days or as soon as the patient can tolerate. If the patient is failing treatment, you want to optimize therapy. You don't want to wait, okay? Now, what about the drug interactions? What things are you going to consider? So before we look at the drug interactions in common, I wanted to list down the drugs that you're going to use for therapy for management of your patients with non-tuberculous mycobacterium. Your key mainstay drug for management will be macrolides. Okay, so here we have azithromycin or clarithromycin. Depending on where you are and who is there, for me, I prefer azithro because it's a 1 daily dose compared to azithro, clarithro, which will be twice daily dosing. So it will be one of your key drugs you're going to use. For patients who are HIV positive and doing well on therapy, you could then just start with dual therapy of the macrolide and the ethambutol. But for those who are failing with very low CD4, high viral loads, then you want to do a combination of at least 3 drugs. So here you are going to add to ethambutol rifamycin, the rifamycin groups, that is either rifampicin or rifabutine. The reason I put there is because now we'll go to look at the drug interaction and see that probably if there's a lot of interaction with rifampicin, you could then consider using rifabutine, okay? Other drugs that have shown efficacy then can be used as part of therapy are things like isoniazid, methotrexate. Bedaquiline is still in a gray area. You have seen it around. So efficacy is still unknown. So it's not recommended for as part of regimen, so still under trials. So these are the main drugs you're going to use. And you remember this patient will take these drugs for at least a year. Okay, so treatment is quite long compared to the 4 months or 6 months we're doing for TB therapy. For NTMs, you're going to go for at least a year. So what are the key things when you are managing? Really, the drug interactions are something that I would like you to pay attention to. So I picked a few drugs. The key idea is just for you to understand the principles. Most of the patients, most of the drugs that we use here mostly, dolutegravir, I think we used to use a lot of nevirapine before, now we no longer. So DTG is one drug I wanted to mention. So if you have DTG and you're treating this patient for MAC and you have rifampicin, that's a dose you're going to give for rifampicin, 600 milligrams. Really, there's that drug interaction, and the recommendation is that you can then double the dose. Okay, so the same principles that we've used. Tenofovir does interact with rifampicin, and what is noted is that your plasma levels of TAF is reduced, but you've got very good intracellular levels. So again, the recommendation is that you might have to use alternative drug regimens that might be available. Darunavir, if it's boosted, you need to avoid because of that significant interaction with rifampicin. And then we think about DTG and dexamethasone, prednisolone, and clarithromycin, there is really no potential interaction, so you can use those drugs. Now, I don't expect you to memorize this table. I want you to be able to use resources that are available for you to be then able to, work out this interaction. So you can get this from the Liverpool drug, HIV drug interaction checker, and you can enter whichever ART you have and which drug you have, and you can get the interaction that might be there. So you can also make reference to the TB and HIV guidelines, because this is covered in the guidelines very, very well. And I think that should be the last slide. Thank you, Dr. Singini.
Wonderful. Thank you so much, Dr. Chanda, for taking us through this presentation. Very enlightening, I must say, especially considering the circumstances around diagnostics and the need to identify patients with tuberculosis. So I found that to be amongst the most interesting aspects of this presentation. So I will then open up the